The urinary system consists of the urine-forming organs known as the kidneys. Humans have 2 kidneys. The kidneys are a pair of bean-shaped organs about 4 to 5 inches long that lie in the back of the abdominal cavity, one on each side of the vertebral column. Each kidney consists of a cortex, which is the outer portion where blood enters the kidney, a medulla, which is the middle portion, and a pelvis, which is the inner portion where filtrate exits the kidney. The nephron is a single functional unit of a kidney. It includes the blood vessels, such as the afferent arteriole, glomerulus, efferent arteriole, and peritubular capillaries. The urinary structures include the Bowman's capsule, the proximal convoluted tubule, or PCT, the loop of Henle, the distal convoluted tubule, and the collecting duct. There are 4 main processes that occur in the nephron: filtration, reabsorption, secretion, and excretion. Each part of the nephron has its own functions. For our purposes, we will focus on the functions of the proximal convoluted tubule, which centers around reabsorption.
The proximal convoluted tubule functions to reabsorb useful molecules such as sodium, amino acids, calcium, magnesium, potassium, all glucose ions, and water from the filtrate produced in the glomerulus. The proximal convoluted tubule is where the greatest amount of fluid reabsorption takes place in order to properly maintain homeostatic regulations in the body, such as blood volume, blood pressure, and pH. Reabsorption is the process in which water and solutes are transported back into the bloodstream after it is filtered. Because of the high reabsorption rate, the inside of the proximal convoluted tubule is lined with simple cuboidal epithelium cells that have a brush border of microvilli, which serve to increase the surface area for maximum reabsorption. Since the proximal convoluted tubule provides both passive and active transport, mitochondria is very abundant inside the tubule to supply the energy needed to perform active transport. Before the filtrate reaches the proximal convoluted tubule, it is formed and filtered out of the blood into the glomerulus. The greatest amount of fluid reabsorption in the kidney occurs here. This includes 65% of water and sodium, along with all glucose and amino acids secreted into the filtrate. The filtrate becomes highly concentrated with other substances. Some ions, such as calcium, magnesium, and potassium, follow their concentration gradients and undergo reabsorption by the proximal convoluted tubule. The PCT also reabsorbs bicarbonate ions to compensate for renal acidosis. Water reabsorption occurs through osmosis or by water channels called aquaporins. It can also happen through co-transport with sodium, which means that water can attach to the sodium and flow through.
Other passive transport mechanisms in the proximal convoluted tubule occur through leaky tight junctions between tubule cells in the paracellular route. Sodium-potassium transport is an active process that requires ATP. The sodium-potassium ATPase pump is located in the basolateral membrane and pumps 3 sodium out across the apical membrane and 2 potassium into the lumen. This causes a potential difference that is established across the wall of the tubule, where it is more negative inside the cell. This electrical gradient then prompts chlorine ions to passively follow the sodium. Chlorine is reabsorbed through co-transport following the sodium in the apical membrane. Almost all small filtered plasma proteins, vitamins, glucose, amino acids, and some ions are also reabsorbed by the proximal convoluted tubule through secondary active transport.
Secretion is the selective removal of substances into the filtrate to be transported out of the body in urine. Multiple parts of the nephron participate in secretion, but the proximal convoluted tubule is the main site for secretion for most substances except for potassium. The PCT is also responsible for the secretion of water into the filtrate, which is achieved osmotically. This filtrate will soon be urine once all needed ions and nutrients are reabsorbed into the bloodstream from the filtrate. In some cases, the body wants to save water. In other cases, it wants to get rid of as much water as it can into the filtrate. How much water is secreted into the filtrate depends upon the body's hydration levels, which are regulated tightly by the hormone antidiuretic hormone, or ADH for short. ADH functions to conserve water in the body when it is running low. If the body is well hydrated, there will be low ADH levels present, and more water will be secreted into the filtrate, producing a high volume of unconcentrated urine. If the body is dehydrated, it will produce high amounts of ADH, which will work to conserve water and prevent it from leaving the body in the filtrate. In this case, less water will be secreted from the tubule into the filtrate. This action will also lead to the production of smaller amounts of highly concentrated urine. Secretion also plays an important role in regulation of the body's pH or acid-base balance. In the case of respiratory acidosis, the proximal convoluted tubules save the day. When the lungs are not working so well, as in the case of chronic bronchitis, cystic fibrosis, or emphysema, there can be a buildup of CO2 in the blood that causes the body to go into acidosis. Unfortunately, since the lungs aren't doing so great, there's not much that they can do to rid themselves of this abundant hydrogen and this respiratory acidosis. This is where the proximal convoluted tubule steps in. It takes on the task of secreting extra hydrogen ions into the filtrate passively via diffusion, as well as holding on to bicarbonate ions, all in an effort to regulate the body's pH. The PCT secretes other substances into the filtrate as well, such as common waste products found in the urine. These include ammonia and creatine, along other organic substances secreted in the filtrate via diffusion. It will also secrete things it can't use into the filtrate, most commonly the waste products of drugs.
What happens if the PCT does not function properly? Normally, almost all glucose from the filtrate is reabsorbed in the proximal convoluted tubule, whereas less than 0.1% of glucose is not reabsorbed. However, this is not the case in hyperglycemia. Hyperglycemia occurs when there's an abundance of glucose circulating in the blood with a concentration greater than 200 milligrams per 100 milliliter. This condition can result from excessive glucose consumption, the lack of insulin, or a defective bodily response to insulin. In the case of hyperglycemia, glucose will be excreted in the urine, a condition called glycosuria. Individuals, such as those with poorly controlled diabetes mellitus, who are hyperglycemic, will present with glycosuria. In glycosuria, the reducing sugars found in the urine include glucose, galactose, lactose, and fructose. The most frequent type of glycosuria is glucosuria, which implies that glucose is present in the urine. This typically occurs when the glomerulus filters more glucose than the PCT can reabsorb. Glucosuria can be due to elevated plasma glucose, as in diabetes mellitus, or renal glucose absorption impairment in the PCT, or both. The capacity of the proximal tubule to reabsorb glucose to prevent its passing to the urine is known as the renal threshold. However, since the filtered glucose exceeds the capacity of the tubular system in patients with diabetes mellitus, the condition glucosuria results.